So today our topic is chronic pyelonephritis, interstitial fibrosis and atrophy of tubules due to multiple bouts of acute pyelonephritis. So in this we have interstitial fibrosis and atrophy of tubules due to multiple bouts of acute pyelonephritis. So we first of all we have acute pyelonephritis, and when you have multiple bouts of it, then you will suffer interstitial fibrosis, and then you will suffer from atrophy of the tubules. So these are two characteristic features: interstitial fibrosis and atrophy of tubules. Now we will learn due to the vesicoureteral reflex or obstruction. So basically in children it is because of etiology की बात करें तो vesicoureteral reflex होता है in children's. So in children basically you know that the control over the ureteral reflex is not that strong. So basically it is in infants or children's, and it is basically because of some anatomical deformity. And then we have obstruction. Obstruction is basically because of BPH or cervical carcinoma. BPH is a benign prostatic hyperplasia in males and cervical carcinoma in females. So when you have a mass which is close to the kidneys or the ureters, then you can cause compression on the kidney, and then it can cause pyelonephritis. So basically because of BPH or cervical carcinoma you can have this. So etiology, there is two: vesicoureteral reflex in children, and in adults it's because of BPH and cervical carcinoma. Now, what it causes? Morphologically leads to cortical scarring and blunted calyxes. So we have cortical scarring and blunting calyxes. Scarring is because of multiple bouts of the infection, and then when you have scarring, you have blunted calyxes. Scarring in the upper and lower poles is characteristic of vesicoureteral reflex. When you have in children, it is because of vesicoureteral reflex, you will have scarring in upper and lower. So if in any scenario you will have the morphological features of scarring in the upper or the lower poles, then it will indicate that it is chronic pyelonephritis. So more morphologically it is that. There is some other morphology that we will discuss, is that uneven scarring, fibrosis, atrophy of tubules. The radiologic image is characteristic asymmetrically. Okay, basically there will be asymmetrically contracted kidney with some degree of blunting and deformity of calical system. So on gross appearance on radiography, you will have asymmetrically contracted kidney. So this is the hallmark: asymmetrically contracted kidney. So it will indicate chronic pyelonephritis. Uneven scarring, fibrosis, and atrophy of tubules is another. So uneven scarring, fibrosis, atrophy of tubules is the other. Radiologic image is characteristic asymmetrically contracted kidney with some degree of blunted and deformity of calical system. Then another thing that we will learn about this is that atrophic tubules containing eosinophilic proteinaceous material resemble thyroid follicles. This is another hallmark, that atrophic tubules will contain a material which is similar to that of thyroid follicles. So eosinophilic proteinaceous material resemble thyroid follicles. So eosinophilic proteinaceous material will resemble thyroid follicle. So it resemble thyroid follicle. Those eosinophilic proteinaceous material that will deposit in them will resemble the thyroid follicles, and waxy casts may be seen in urine. And secondly, then we will see waxy cast in urine. So waxy cast in urine. So basically, for chronic pyelonephritis, 3-4 hallmarks: cortical scarring, blunted calyces, uneven scarring, uneven contraction, uneven contracted kidney with some degree of blunting and deformity of calical system. So, and the other one is atrophic tubules containing eosinophilic proteinaceous material resemble thyroid follicles. So this is called thyroidization of kidney. Waxy cast may be seen in urine. And then another thing is that waxy cast may be seen in urine. So, if we summarize it: interstitial fibrosis and atrophy of tubules because of multiple bouts of acute pyelonephritis. Etiology: vesicoureteral reflex in males, BPH, and cervical carcinoma. Leads to the cortical scarring, blunted calyces, uneven cortical scarring because of an obstruction because of BPH, and in male it is because of vesicoureteral, female BPH. उसके बाद क्या होता है कि atrophic tubules containing eosinophilic proteinaceous material which resemble thyroid follicles, so this is called thyroidization of kidney, and waxy cast may be seen in urine. So if we say waxy cast is seen in urine, morphologically there is scarring, there is uneven contracted kidney, there is a waxy cast in urine, so you will say it's chronic pyelonephritis. Next, nephrolithiasis. Basic principle. Precipitation of urinary solute as stone. Risk factors, basically when you have precipitation of urinary solute as stone, it is called nephrolithiasis. Risk factors include high concentration of solute in the urinary filtrate and low urine volume. So when you have high concentration of solute, it's because of low when you have low levels of hydration, first of all, and secondly when your salt intake is greater than the normal value, then it will affect you. And basically this is it will have the deposition of calcium oxalate salt and somehow some concentration of calcium phosphate salts. The risk factor to include high concentration of solute in the urinary infiltrate. So when the urinary infiltrate have high concentration of solute, when it will flow through the tubules of the kidney, some of the salts will precipitate and it will calcium and oxalate ions will bond to form calcium oxalate and they will concentrate in the tubules of the kidney, in the parenchyma of the kidney, in the calyces, first in the calyces and then it will move into the parenchyma. So basically they will be present in the pyramids of renal medulla. Low urine volume. Okay, so because of the two etiologies, first high solute in the urinary infiltrate, majorly calcium and phosphate and oxalate, and secondly low urine volume. Present as colicky pain with hematuria and unilateral flank tenderness. First of all, you have hematuria, you will have blood in urine. Colicky pain, there will be it will be a pain of somehow you will think that it is a colic pain, and unilateral flank tenderness, so you will have tenderness in the flank area. So unilateral flank tenderness. So these are the presenting complaint: colicky pain with hematuria, unilateral flank tenderness. Stone is usually passed within hours. If not, surgical intervention may be required, and radiotherapy is also available nowadays. Okay, so the presenting complaint will be colicky pain with hematuria and unilateral flank tenderness because of high solute concentration and second low urine volume, and this is called nephrolithiasis. Next topic is chronic renal failure. Okay, chronic renal failure is basically end stage kidney disease. It is an important topic. May result from glomerular, tubular, inflammatory, or vesicular insults. Okay, end stage renal failure. So there you can have insult on any level of the kidney. First of all, starting from the glomerular, it may be because of any glomerular related disease, nephrotic, nephritic, to tubular, it may be because of tubular necrosis. Inflammatory, it will be because of pyelonephritis, and vascular insults, it may be because of angiitis or something like that. Most common cause are diabetes mellitus, hypertension, and glomerular disease. So these are the main cause: the diabetes, hypertension, and glomerular disease. Clinical features: uremia, salt and water retention, hyperkalemia, anemia. Uremia is because of the function of the kidney is to excrete the excrete the urea. So if the kidney is not functional, so the urea will concentrate in the blood and it will cause uremia. Simple. Increased nitrogenous waste products in the blood, which is basically another word for that is azotemia. Results in azotemia is basically high BUN. It will be everything, like it will be urea, it will be nitrogen. Results in nausea, anorexia, pericarditis, palatal dysfunction, and sphelopathy with asterexis and deposition of uric crystal in skin. So the manifestation of uremia will be like nausea, anorexia, pericarditis. So nausea is because of high levels of urea in your blood. It will cause nausea, anorexia. Because of high levels of urea in the blood, you will not have the um, you know the any kind of appetite. And second, they have pericarditis because the circulating blood with high levels of urea can cause infection of the pericardium. Platelet dysfunction, it is also because of that, and encephalopathy, so it will cause brain dysfunction as well, जिसकी वजह से एस्ट्रेक्सिस होगा और स्किन में भी हो सकता है. So nausea, anorexia, pericarditis, platelet dysfunction, encephalopathy, astraxis, and deposition in the skin. Salt and water retention with resultant, okay, if the salt and water is not excreted, it will cause hypertension. Hyperkalemia, if the potassium is not, it will cause hyperkalemia, which is called metabolic acidosis. Anemia due to decreased erythropoietin production by renal peritubular. Okay, there is another function of the kidney, that is the production of, you all know, erythropoietin. Erythropoietin is basically the precursor to erythroplasts and which is a precursor to red blood cells. So if erythropoietin, which is made by the kidney, is not produced, so there will be low levels of production of red blood cells, and the low levels of red blood cells will cause anemia. So erythropoietin and the other function of erythropoietin is also storage of iron. So if the iron is not stored, so it will cause anemia. So anemia due to decreased erythropoietin production by renal peritubular interstitial cells. Hypercalcemia. Other manifestations are hypercalcemia. Okay, hypercalcemia due to decreased okay, we all know that the hypocalcemia is because of decreased 1-alpha hydroxylation of vitamin D by the proximal renal tubule cells and hyperphosphatemia. Okay, basically vitamin D, the end product of vitamin D is produced in the kidney, which is the last step in vitamin D production, as we all know, which is called 1-alpha hydroxylation. If 1-alpha hydroxylation is not done, then there will be low levels of vitamin D, and when there is low level of vitamin D, it will call hypocalcemia, because there is another function of vitamin D which is called extraction of calcium from the bones into the blood. And when the vitamin D is not present, the bones will not excrete, or you cannot get the calcium out of the bones into the blood. So it will cause low levels of calcium in the blood, which is called hypocalcemia. Proximal renal tubule cells, and that will, and the other function of the vitamin D is also excretion of phosphate. So when phosphate is not excreted, it will called hyperphosphatemia. So the levels of phosphate in the blood will increase, so it's called hyperphosphatemia. So this is another function. This is another manifestation: hypocalcemia and hyperphosphatemia. Renal osteodystrophy due to secondary hyperparathyroidism, osteomalacia, and osteoporosis. So another thing is that renal osteodystrophy. There is another thing which is called renal osteodystrophy due to secondary hyperparathyroidism, osteomalacia, and osteoporosis. Renal osteodystrophy due to secondary hyperparathyroidism, osteomalacia, and osteoporosis. Um, Osteodystrophy होगी due to secondary hyperparathyroidism. When there is low levels, when there is parathyroid because of hypocalcemia, now parathyroid gland will activate, and the function of parathyroid gland is what? Is the blood. It will excrete the calcium from the bone into the blood, so it will cause secondary renal dystrophy, which is called osteomalacia, due to secondary osteomalacia and osteoporosis. तो because of secondary hyperthyroidism, तो इसमें क्या होगा? इसमें osteomalacia होगा and osteoporosis होगा. So the functions, the manifestations of this is uremia, first of all. Secondly, anemia. Salt and water retention will be called hypertension. Osteomalacia, hypercalcemia, hypocalcemia, hyperphosphatemia. Then there will be hyperkalemia, which is called metabolic acidosis. Then we have renal osteodystrophy because of secondary hyperparathyroidism, which will be called osteomalacia and osteoporosis. Done. Treatment involves dialysis or renal transplant. So there is two treatments: dialysis or renal transplant. Cysts often develop within the shrunken end-stage kidney during dialysis, increasing risk for renal cell carcinoma. So dialysis and renal transplant, these cysts भी बन सकती है. So this is the account for chronic renal failure. So basically it is because of diabetes, hypertension, glomerular disease. Manifestations are, as we discussed, treatment is renal failure, is end-stage renal dialysis or renal transplant.